Professor Jonas Rosendahl, who's speaking to us today from Germany. He represents the Martin Luther University in Halle-Wittenberg. I've had the pleasure of working with Jonas on a number of projects. He is a European and international expert on all things really pancreatology, but is really leading in definite guidelines and just getting the message out there for chronic pancreatitis, having been on lead author on the Pancreatic EU guidance. He's setting up a autoimmune pancreatitis database now as well. He's author of over 100 publications, and he and we are really seeing now a lot of problems coming in with a new disease, which seems to be a fatty pancreas, and I'm really be keen to hear his thoughts on this today. And I'm absolutely honoured for you to join us today, Jonas. So I'll hand over to you, and thank you very much for your presentation.
Dear ladies and gentlemen, dear Chairman, Andrew, it's a great pleasure and to have the opportunity to speak here at this wonderful meeting. I start to like these online meetings, but it's not as good as being really in the place to be, which would be Sheffield now. So the title of the talk will be Pancreatic Steatosis, does the silent partner in metabolic syndrome now have a voice? And at the end of the talk, for sure, you will see that we know a lot of evidence and things about pancreatic steatosis, but on the other hand, we don't know the real mechanisms, and maybe this is really an important field that we should focus on in the future and conduct more research in this field, which is really of importance. So here are my conflict of interests, not very many, which is mostly the case if you are doing pancreatic research. And before we start, I just want to briefly show you a short reminder. And this reminder will show you something that is quite strange. For example, in Germany, that the exocrine and the endocrine portion of the pancreas, which are equally important, are completely treated by different physicians in our country. And the same holds true for the research that we conduct in these parts of the pancreas. So all of you know that the exocrine portion is a little bit bigger than the endocrine portion if you take the mass of the pancreas into account, so it's 85% of the pancreatic mass. You know that Esner cells and digestive enzymes, the ducts and the fluid is the most important tasks that this portion has for the digestion of the food. Of course, on the other hand, the endocrine portion, 15% of the pancreatic mass, secretes very important hormones, insulin, glucagon, somatostatin, pancreatic polypeptide. So both of these portions are equally important, even if the mass is different represented in the organ. And one of the things that highlights that it is really important that we work together in this field is that the blood flow will flow from the endocrine to the exocrine portions. So all the hormones will pass the exocrine portion, and there must be an interaction between both parts also for the development of diseases that are located in the exocrine portion, like exocrine pancreatic insufficiency. So we start with diabetes patients in this regard and take a look whether there are changes in these patients that might give a clue that there is an exocrine misfunction in these patients. And if you take a look at really old investigations that have performed throughout the years, then you can see that patients with diabetes demonstrate a lot of morphological changes that you can even see in patients with chronic pancreatitis in the end. So you see atrophy in these patients, a fatty pancreas, that's what we are talking about, pancreatic steatosis, fibrosis, and then you see really duct changes that are comparable to chronic pancreatitis. And it seems that these effects are a little bit more pronounced in type 1 compared to type 2 diabetes. So taking this into account, it seems that there's a clear link between such a disease, the endocrine portion and the exocrine portion in the end. And maybe there's even more explanation of the consequences that diabetes or the metabolic syndrome has for our patients that we treat in hospitals. So what can we do to really put this on stable grounds? There's one option that we can measure the volume of the pancreas and compare it between diabetes patients and patients that are healthy. And this was done in this very elegant work published in 2014. Here, an MRI measurement was undertaken. And what you can see is the interesting result that the volume of the pancreas in diabetes mellitus type 2 patients, it's just type 2 patients, no type 1 patients, is lower compared to controls. And if you take a look at the rough numbers, then you can see that it's about 18 milliliters lower in the diabetes mellitus type 2 patients compared to the controls, which accounts for around 20% of the volume. So the message of this evaluation is that even in the diabetes patients, several mechanisms must be present that lead to chronic inflammation and a change of the composition of the whole pancreas, and that also affect the endocrine portion, the exocrine portion of the organ. So the next question would be, does this have any consequence in the clinical setting? And I think most of us, also we are maybe not treating most of the diabetes patients, do neglect this potential effect that diabetes must have on the exocrine function. So if you take a look at not so old data, but summarized in a meta-analysis from 2018, then you can see that if you take the gold standard test, direct test of pancreatic function, up to 80% of diabetes patients have mild exocrine pancreatic insufficiency. But, and this will go throughout the talk, we have to take into account that the cohorts investigated here are rather small. So it's up to 60 patients that have been investigated by direct pancreatic function tests. If you use other pancreatic function tests, the numbers remain nearly the same. So it's up to 74% of patients with diabetes, here type 1 and type 2, have a mild exocrine insufficiency. And it seems that the prevalence is a little bit higher in type 1 diabetes patients, which might be logical because the inflammation or the disease in this organ is present for a longer time than in type 2 patients. But we really have to take into account and remember this throughout the talk that the numbers investigated are rather small. And I think we need more trials and better trials to understand what is happening here. So the next question is, what comes first? Is it the endocrine insufficiency that causes exocrine insufficiency, or is it vice versa? If you take a look at the knowledge we have today, it seems rather that the exocrine pancreatic insufficiency in patients with chronic pancreatitis, with diabetes mellitus, is the consequence of the diabetes and not the other way around. So one explanation might be that we have a reduced amount of the growth factor insulin in these patients. We might have diabetic microangiopathy that leads to pancreatic fibrosis in these patients. And of course, like in other diseases or in obesity per se, there must be subclinical inflammation also in the pancreas in these patients that causes atrophy, which seems to be mediated by pancreatic stellate cells and factors like TGF-beta. We might have neuropathy remodeling, and this leads to a disturbance of enteropancreatic regulatory circuits, which might explain how exocrine insufficiency develops in the end. And of course, we can also always say it's like genetics. The microbiome is responsible for the exocrine insufficiency in these diabetes patients. It's good to explain everything, the microbiome, but maybe in the end it explains not as much as we hope so far. And one thing that is important here in all of these studies and explanations that the authors try to give how the exocrine insufficiency develops in these diabetes patients is that all these patients had insulin deficiency and they're investigated in this stage. And we need more data in the patients with type 2 diabetes and that insulin is still present and there's no deficiency. So we have to be really cautious with the interpretation of the results. So in this graph, the authors summarize how the interaction could be between diabetes and pancreatic exocrine insufficiency. And it seems that we have, of course, as stated before, an interplay between the endocrine and the exocrine portion. Several factors like insulin play a role in this regard. We have immune cell infiltration, maybe as a consequence of ectopic fat disposition in the organ, and these mechanisms then lead most of all to pancreatic stellate cells activation and thereby to fibrosis in the organ, so that we can really see in these diabetes patients morphological changes that are comparable to the ones that we see in chronic pancreatitis. But to say once again, we are really not sure which is the hen and which is the egg, but it seems more likely that diabetes comes first, and the consequences are all these mechanisms that are listed here in this graph. So what are we going to do with our diabetes patients? Is there a large cohort of patients that are undertreated so far? This is a suggestion by the authors of this manuscript published in 2020 that say, if you have patients that have symptoms of exocrine insufficiency, you should take into account in these diabetes patients that exocrine insufficiency is present. So you need a further diagnostic workup that is also taking into account diet-induced or medication side effects. You should, of course, rule out other diseases like celiac disease, bacterial overgrowth. Take a look at the blood glucose control, and of course on further diseases that can develop in the later stages of diabetes patients like neuropathy or others. And if you have severe symptoms and are not going to find any other disease that explains the symptoms in the patients, then for sure imaging is a good step forward, because other diseases like pancreatic ductal adenocarcinoma could be the explanation. And for sure, you would like to have a picture then of the pancreas to see how it looked like. And of course, and this is important, dietary counseling then, testing of fecal elastase. Also, we are all aware that this test is not the best on the world, but is the test that we have available. And then you should consider to start pancreatic enzyme replacement therapy. As all of you know, if pancreatic exocrine insufficiency is present over a long time, there might be consequences for the patients which really could harm them in the future. So maybe we shouldn't be too strict with the starting of the treatment in this cohort of patients. So now we move away from diabetes, and the main topic that we are now going to speak about is the pancreatic steatosis, which for sure is correlated with overweight and obesity. And all of us are aware that overweight and obesity are really some of the major problems that we all have to face in our daily clinical practice, and that will not vanish in the next couple of years. And maybe other restrictions than bariatric surgery are necessary to get a hold of this really complex disease. So what the question might be is, we are all aware that pancreatic steatosis is seen quite commonly in patients, but we need quite good measurements to really understand and compare the amount or the grade of steatosis of the pancreas between different patients. Thus far, it works quite well with ultrasound, abdominal ultrasound, and then the comparison to the echogeneity of the liver and the spleen or the kidney. But if you would have a method that really gives you some rough numbers to compare the amount of pancreatic steatosis, this would be nice. So I want to show you a recent work that was performed by the group of Seguin et al. That used two-dimensional shear wave elastography to assess the stiffness of the pancreas and to correlate it with pancreatic steatosis and with the metabolic syndrome. So in total, 125 patients were enrolled. You see that roughly 70 patients had pancreatic steatosis, while 57 had no pancreatic steatosis. And in these patients, the group then compared the shear wave elastography values with several aspects. What you can see, and this is something that we have also known before, is that the metabolic syndrome really correlates very well with pancreatic steatosis. In this investigation, up to 20% of the patients had with pancreatic steatosis had a metabolic syndrome, whereas in the group of patients with no pancreatic steatosis, only 3.5%. So this is highly significant, but it's not too new because this has been reported before. And another important issue is that, of course, NAFLD correlates very well with pancreatic steatosis and vice versa. So the question remains whether there are patients that only have NAFLD and no pancreatic steatosis, or only pancreatic steatosis and no NAFLD. So to show that this might be different disease entities in these patients. But coming back to what I said before is that the share wave elastography seems quite good to measure the pancreatic stiffness, which correlates with the pancreatic steatosis amount. You can see an important finding, as suggested here in this cohort, is that no matter which part of the pancreas you are going to measure, head, body, tail, is quite consistent. So if you get a good window to measure the elastography of the organ, this seems to be representative of the whole organ, which is an important message, I think, for further studies that for sure should confirm this finding, because the numbers are not so huge in this study. And again, the metabolic syndrome correlates very well with pancreatic steatosis in this group too. You can see that the relative risk, if you have high levels of pancreatic steatosis to have a metabolic syndrome, increased dramatically. So it's an odds ratio of 4.5 in this cohort. So this is really something which is linked to each other. And now the real question for all of us is whether the link is always given with fatty liver disease, or whether there is also an alone standing disease entity, the pancreatic steatosis. Here, then the proof that it's not only the pancreatic steatosis that correlates very well with the prevalence of metabolic syndrome, but also the elastography values. So it seems very reasonable to use this tool in future studies in our clinical settings, and even in further studies that might address other questions than this proof of principle study presented here. One last point that might be interesting, but again, I think we have to be very cautious with the data, is that the role of pancreatic steatosis might be even bigger in other diseases like pancreatic cancer. And this is a work that was also published recently that retrospectively investigated patients with pancreatic cancer and had a look at CT scans, native CT scans that were performed at least 1 month up to 3 years prior to the diagnosis of the pancreatic cancer. And in these patients, they used another method to assess the pancreatic steatosis by the pancreas to spleen ratio, which should be under 0.7 in Hounsfield units. And what they found out is that it really seems to be the case that pancreatic steatosis is also a risk factor for pancreatic cancer, or at least correlates with the development of pancreatic cancer. You can see that in total, and again, numbers are very small, 32 cases have been included, whereas they used 117 controls. And in the patients that had PDAC developed and diagnosed retrospectively in the time before up to 3 years, 72% of these patients had pancreatic steatosis compared to 45% of the controls. That is statistically significant, and it's even significant if you adjust for BMI or diabetes later on. So all in all, it seems that pancreatic steatosis is of importance for sure. And it's quite astonishing that we haven't performed so much more research on this, because there are, I think, a lot of interesting questions left. And maybe it's not always the alcoholic fatty liver disease that explains everything in these patients. So let me shortly summarize. Most of all, you will find pancreatic steatosis and fatty liver disease together. But it seems that there are groups of patients in that you find the one or the other, and maybe these are, for the first studies that we should perform, the most interesting patients. Regarding diabetes, it seems rather that diabetes is the cause of pancreatic steatosis and then exocrine insufficiency. And I guess the key message here is that we have to take a closer look at these patients and really think about substituting pancreatic enzyme in these patients. Regarding pancreatic steatosis, novel methodologies like the elastography of the organ seem reasonable to assess the pancreatic steatosis amount so that we really can quantify this. And it is at least to be discussed that even pancreatic steatosis might increase pancreatic cancer risk, but I think the data are quite vague, and we really have to see whether further studies can confirm this or whether this is just a normal side effect that you can expect in patients with pancreatic cancer, that they have the years before a little bit more fat in the pancreas. And the remaining question, or the remaining point, is that we obviously need more research, and I think we all should think about this and look for good topics that we should answer in this regard. So thank you very much for the opportunity, and I'm ready to take questions if there are any.
Jonas, yeah. Jonas, thank you. Amazing as expected, but and we gave you such a hard topic there because, as you say, the research is developing rapidly, and there is so many different aspects to this. We've got a number of questions come through. If you don't mind, we'll try and get through as many as we can. I suppose Manu of Newcastle, who's going to speak later, has asked about do trials now, and there's been a lot of trials on diabetes and PEI. Do trials now need to really assess pancreatic steatosis? And if that's the case, should we be doing MRs in all patients in these studies, really to look and really assess what the link is and why it's happening?
Yeah, it seems that MR is a very good method to assess the steatosis rate, maybe the best one, but it's quite expensive, and so it's hard maybe to get this done in all the patients. It's good news that abdominal ultrasound is also capable to do this, to assess it quite, if we use share waves to assess it with numbers so that it's really comparable. Regarding the relevance, I would say that maybe we should take a look at all the longitudinal cohorts that are available, like SHIP cohort or so, where 4,000 patients have MRIs, and the MRIs are there, and we just need somebody who's going to evaluate all these MRIs and correlate them with all the data that are available there. So then maybe this question can be really answered with a solid scientific ground, if MRI is the only thing that we should go forward with.
And there are a number of us online who do endoscopic ultrasound at the moment, and Matt Huggett, who's going to speak in later, has been asking as well, is it something that we should now start incorporating into our sort of training and practice, this recognition of a fatty pancreas, is because it's something that's going to be becoming much more prevalent, and the questions are going to start being asked of us is steatosis seen on ultrasound, and is it the cause of the symptoms? Do you think it causes pain or symptoms, fat in the pancreas?
Oh, I don't think it causes symptoms. At least not pain, but maybe exocrine insufficiency symptoms. But this is just from the clinical background that you see a lot of patients with liver cirrhosis and really rough morphological changes of the pancreas, and they never have complained of pain. So I would suggest or imagine that this doesn't cause pain, but it might cause, for sure, other problems like nutritional defects or whatever. And I think it should be included in endosonography training, because we should be better in regard of the pancreatic steatosis, as this might be as important as non-alcoholic fatty liver disease, and the focus throughout the world is much more on the liver than on the pancreas, which is not correct.
It should never be the case, no. So last question. Do do you advocate screening for PEI in type 2 diabetes? With looking at pancreatic cancer cohort screening now, aren't we? I think in the diabetes population, and it's. Do you think this is something where we should now start thinking actually we should start screening patients for this, and which groups particular?
Oh, I think this is absolutely reasonable to do this because we neglected this over years. And if you take into account the data that are published recently, for example, from the States, how patients are undertreated, even if it's quite obvious, chronic pancreatitis patients and pancreatic cancer patients, that pancreatic exocrine insufficiency might be of importance, then in this cohort, we will find a lot of patients that have pancreatic exocrine insufficiency and will benefit in the end by substituting the enzymes, as this might have several consequences published thousands of times, most of all by good groups from the UK. So I think it's very important to do this.
Okay. Jonas, thank you ever so much for your time this morning. We're going to let you go now, all right, and I hope to catch up with you soon about the number of projects we've got going on, and all the best, and take care. Okay.
Yeah, thanks a lot. Bye.
Okay. We're going to have a 5-minute sort of interval now where you'll see a holding slide come up. There's Twitter handles and things. Hopefully you can go get yourself a coffee, and we'll then restart the next session at 10:15 if that's okay with everyone. So see you in 5 minutes. Okay, goodbye.